Okay, morning everyone. And a warm welcome to all those joining us online as well as in person for the Friday academic meeting. Our presentation is from the Division of Geriatric Medicine, and we're talking about a very common geriatric syndrome that we encounter. And I'm sure everyone sitting here has one way or another come across an older person complaining of this problem. And certainly from a geriatric perspective, we know when a patient presents with this as their presenting complaint, we pretty much know that that consultation is going to be a bit more longer, because there's a couple of things you need to assess for in history. Taking an examination can be a little bit overwhelming, but to help us understand and have a decent approach to persons with falls, and also to give us reasons why we should not probably ignore this complaint. We have our presenter today is Dr. Tasneem Bux. She's one of our fellows rotating through the department. She's almost finished with her program, almost there. So I'm happy to have her. Thank you so much.
Thank you. Good morning, everyone. So today, as Anu said, I'm going to be taking you through falls in the elderly. It no move. I'll click here. Next.
Yeah.
Okay, perfect. So just the outline of today's presentation, we'll be talking about the definition of a fall, some information on incidence and prevalence, sarcopenia and how it relates to falling, the physiology of falling, as well as an approach to falls with specific emphasis on history and examination. Briefly touch on consequences and complications, and then there are some cases that we'll look at. So falls are one of the most common and serious issues contributing to disability amongst older adults. So a fall is defined as an event that results in a person unintentionally coming to land on the ground or a lower level, and not as a result of a major event such as a stroke or a seizure or an overwhelming hazard. There is a direct correlation between falls and morbidity, mortality, and decreased functionality in the elderly. So falls increase steadily after the age of 65. 1 in 4 older adults reports having fallen in the last year. And there's an increasing incidence with each decade of life. So 50% of those who have fallen are recurrent fallers, and 30% of those who fall will suffer serious injury. Falls are the leading cause of injury-related death in those 65 years and older in the United States. So this study was done to establish a prevalence for falls and identify risk factors for falls in the community-dwelling older population in South Africa. It was conducted in Cape Town, in 3 suburbs with a relatively high population of adults older than 65 years. And the baseline interview used structured surveys. Some of the data was self-reported, and there was also a physical performance assessment. And the prevalence of falls in this sample was 26.4%, with a recurrence rate of 11%. This table is from a systematic review entitled Global Prevalence of Falls in the Older Adults, a comprehensive systematic review and meta-analysis. So it comprised of 104 studies with a total sample size of over 36 million. And the prevalence of falls in the older people of the world was 26.5%. So falls are multifactorial in etiology. And one of the contributors to falling and a key component of frailty is sarcopenia. So sarcopenia is a progressive and generalized skeletal muscle disorder that is associated with an increased likelihood of adverse outcomes, including falls. It begins in the 4th decade, estimated at 8% per decade, and from the age of 70 increases. There's 50% muscle loss in inactive older adults older than 80 years. The term has its roots in the Greek language, and it literally means poverty of flesh. So it's usually accompanied by physical inactivity, decreased mobility, poor endurance. Risk factors include age, gender, and level of physical activity. And as I've said, it's a key component of frailty. So various things that are related to physiological changes with age contribute to the physiology of falling. So one of these things would be decreased muscle mass and strength. So you have stiffening of connective tissue, leading to decreased range of joint motion, there's loss of muscle mass and sarcopenia. Neurologic changes include an increased reaction time because of slowed nerve conduction, decreased writing reflexes, as well as decreased proprioception. Visual changes include decreased visual acuity and contrast sensitivity, as well as reduced depth perception and accommodation. Gait also changes as we age, with increased lateral sway, decreased stride length and reduced arm swing, increased flexion at the shoulders and the knees, and a shift in the center of gravity. The elderly are also more prone to hypertension due to decreased baroreflex sensitivity to hypotensive stimuli, and they are also more prone to dehydration with a decreased total body water. So this schema highlights the relationship between gait and cognition, and the role of the brain motor control center in fall risk. So inattention and impaired executive function lead to slowed gait and instability and difficulty with performing the classic rescue strategies or writing strategies. So how do we approach falls in the elderly? So the most important way to identify older adults who are falling is to ask them or their caregivers. Based on the answer that you receive, you can then plan an approach to the assessment of the patient. This is a helpful algorithm, but it's obviously not set in stone, especially if you are dealing with a patient who has not yet fallen, but may have multiple risk factors. So falls are often a marker of underlying intrinsic problems or environmental or behavioral risk factors. So intrinsic factors are some of the age-related physiological changes that we've discussed, as well as diseases that affect the risk of falling. So these include things like orthostatic hypotension, Parkinson's disease, stroke, osteoarthritis, and cognitive impairment. Extrinsic factors include hazards in the home or in the area, poor lighting in areas, inappropriate shoes, and inappropriate assistive devices for that person. So when you are taking a history, alongside the usual questions that you ask in your history, this is also a helpful mnemonic to remember things that you should question people or their caregivers who are falling about. So especially if they do have a caregiver, if they are an older adult, do they live alone? An explanation of how the home is set up, alcohol use, including the possibility of withdrawal, as well as medications, including over-the-counter medications that they are taking. So an examination is then obviously also an important part of your assessment. Another helpful mnemonic to remember things that you should specifically be looking for in older patients that have come to you because they are falling, or in a patient that you have assessed as having fallen or having a fall risk. So particularly with regards to blood pressure, a reminder to just check supine and standing blood pressure for orthostatic hypotension. So the timed up and go test forms an important part of the examination. And so with this test, you instruct the patient to get up from the chair that they are sitting on without using their arms. They walk 3 meters that you have pre-marked for them. They turn around, come back, and sit down. They should be wearing their regular footwear, and if they do use an assistive device, they should be using it during this test. And no physical assistance is supposed to be given to the patient during this test. So 10 seconds or less is normal. Whilst a score of 14 seconds or more has been shown to indicate a high risk of falls. There are also additions to this test. So you can do a timed up and go manual, so where they do the walking while carrying a glass of water, or the timed up and go cognitive, where they are walking while counting backwards from an arbitrary number like 100. So this image just indicates the wealth of information that can be gained from a timed up and go. And it also reminds us about characteristic gait patterns to look for in the elderly, breaking it down into its base steps. So the timed up and go is a simple test, but it really can provide you with a wealth of information. So additional tests that can be done as part of examination of the patient. The sit to stand test is also one that we commonly use, and it assesses functional lower limb strength, transitional movements, as well as balance. And both the timed up and go and the sit to stand tests have excellent inter-rater as well as retest reliability. The Romberg test is also important, and these are other additional tests that test walking and balance in your patients. So some common and inexpensive blood tests may be needed as part of your investigation, and a baseline ECG and urinalysis should also be done. And then your history and clinical examination will then guide further investigations. But these are some of the further investigations that you could be doing. So the Morse fall scale is a questionnaire that should be performed at admission to hospital and reviewed upon any change in condition of your patients, because 10% of falls occur during an acute illness. So 1 in 200 hospitalized patients fall, and this increases the injury rate. The NHS UK inpatient fall rate ranges between 2.9 to 13 falls per 1,000 patient bed days. So there's a paucity of information regarding inpatient falls in South Africa and in Africa, but the Mediclinic group is one private hospital group that reports on their adverse events, which includes falls. And they have also recently included a falls breakdown, so which looks at the proportion of falls that results in injury. So they operate about 50 hospitals in Southern Africa. So this is about 9,000 beds that this data comes from. So interventions to reduce falls are particularly effective when targeted at the individuals at the highest risk. So various methods have been tried and tested by researchers, but those reported in the literature to be effective either singly or in combination include regular physical exercise, so strength and balance training. It's a good idea not to tell someone who's already falling to just walk more without, getting an assessment, having them see a physio or a biokineticist to work on the strength and balance before you then encourage them to walk. Cognitive and dual task training, so walking while doing things as well, and then Tai Chi and yoga. Cataract surgery and correction of refractive errors, proper footwear, and also proper assistive devices. So a lot of people will just go to Dis-Chem and buy their own assistive device, but it's actually quite important to be assessed for the right assistive device for you and then to be trained in how to use it properly. Environmental adaptation, and then screening and treatment for osteoporosis. So certain drug classes are also considered fall risk increasing. And so this is why medication reviews and deprescribing is also important. So in geriatrics, we commonly look at criteria such as the Beers criteria or the stop-start criteria for rational prescribing in the elderly. The elderly often use over-the-counter medication, which may interact with their prescribed medications as well. And they often have multiple prescribers who may be prescribing the same medications or medications that interact. The average patient at Helen Joseph Hospital attends 3 outpatient clinics. So there is a lot of opportunity for medication errors in prescribing and then in use. And there are significant associations between falling and the use of sedatives, hypnotics, benzodiazepines, and also, as you can see from this list, antidepressants. Just a reminder also that we do have more lenient blood pressure targets in the elderly. So these are 2 tools that have been designed to enable clinicians to deprescribe safely. The stop fall criteria includes 14 classes of medication, the majority of which are psychotropic medication, but it also includes diuretics and alpha blockers. So they advise in which cases to consider withdrawal of the medication from your patient and whether or not a stepwise withdrawal of that particular medication is needed. The stop frail criteria advise withdrawal of inappropriate or unnecessary medications in conditions of end-stage irreversible pathology, poor 1-year survival, severe functional or cognitive impairment or both, and when symptom control is the priority rather than prevention of disease progression. Assistive devices. So these are also part of your interventions to decrease falls. So mobility devices, as previously mentioned, such as crutches and frames, should ideally see the patient being assessed and then having the right aid prescribed to them. Personal safety devices, such as bed alarms, can help alert carers and family members to the fact that a patient needs assistance. Installing rails along stairs, in the bathroom, by the side of the toilet, as well as providing chairs in the bath or in the shower, and using transfer devices to get from a bed to a chair or from outside of the bath to into the bath are also helpful, as well as raised toilet seats in the elderly. So falls are the most common type of trauma experienced by the elderly, and they result in many hospital visits. They are also very expensive, can result in serious injury, and they can have severe social, psychological, and functional consequences. So patients with a fear of falling limit their movements, and they often isolate themselves in their attempts to prevent falling. So the consequences, or the complications rather, are commonly seen, particularly when we have patients with hip fractures. And aside from the fracture itself, many complications can and do occur in these patients. And this increases as the duration between admission and definitive surgery increases. So falls resulting in hip fractures, although only 2% of falls will result in a hip fracture, they do have serious consequences. So 17 to 25% of older adults who have sustained a hip fracture will be dead within 1 year. And there's a 20% lower risk of death within 1 year if they are operated on within the first 48 hours. 60% of these patients will have restricted mobility. And this relates to the fracture itself, as well as the complications that may arise when one has sustained a hip fracture. So just a word on anticoagulation and falling, because anticoagulants are often underused in the elderly due to concerns about falling whilst on anticoagulation. So if you have done a falls risk assessment in your patient, this can help improve your decision-making. However, the absolute risk is low, and it's outweighed by the reduction in stroke risk. In many centers, direct oral anticoagulants are now the preferred choice due to their safety profile and ease of use. And the off-label dose reduction of these agents is actually not recommended. There should be a per-patient individualized approach on decision-making in the elderly. And you should consider deprescribing anticoagulants in patients with extreme frailty or in cases of end-of-life care, as well as in cases where your patient has made an informed decision about anticoagulation and chooses to rather not be on it. So just to go through a few cases. So we had a patient, Mr. CS, who was a 69-year-old male. He was actually referred from a GP to the geriatric clinic with cognitive slowing. And on history, we found that he had fallen once in the last 6 months, and he'd been having instability for about 9 months, and he also had a fear of falling. So if we look at our algorithm, with a single fall, we're going to check him for gait and balance problems. So his timed up and go is actually 22 seconds. And when we observed his walking, he had a slow shuffling gait with short steps and a reduced arm swing. So on further history, he also told us that he had this tremor in his right hand, and he was an artist and he could not actually draw. And on further examination, we found more features in keeping with Parkinson's disease, and he was started on treatment and he actually responded really well. We've seen him twice now again at the clinic, and a lot of his symptoms have resolved. He doesn't have a lot of off time, and he's had no further falls. This was another patient that we saw, an 84-year-old lady referred from a GP. She had had 8 falls in the preceding week, but she also had multiple falls prior to that. So you can see she takes amitriptyline for breakfast, trazodone. So trazodone forms part of the antidepressant class, but it's very sedating. And the usual dose is 50 milligrams. This is 3 times it's sedating in the same way that Phenergan will put you to sleep for 16 hours. So will trazodone. And so she was also on a benzodiazepine as well as a diuretic. So obviously the intervention here was, look at all these medications. Is there an indication for any of these medications? Stop the medications. She was very unhappy. But unfortunately for her, sorry, I don't think my blue projects that well, but you can see she'd also, CT scan showed that she'd sustained a chronic subdural. And then our final patient, an 81-year-old female, she was living in a care facility, but she was in the independent living section of that facility. And she sustained a fall and subsequently an ecopemur fracture. So from her medical history, she had metabolic syndrome. And she'd had a STEMI in 2014, and for some reason was still on clopidogrel 10 years later. So unfortunately for Mrs. AG, her surgery was initially delayed due to the use of clopidogrel, and then it was further delayed because she developed a nosocomial pneumonia in hospital. So she eventually did have surgery 4 weeks after being admitted. And so now, from a patient who was in independent living, she's now predominantly wheelchair bound, and she requires assistance with even the basic activities of daily living. So my take-home messages from this are that falls are common, and patients may not volunteer this information, especially if they have not sustained an injury. So it's an important thing to ask your patients about. A timed up and go test can provide a wealth of information about your patient and their fall risk. And falls generally have a multifactorial etiology. So we are often not able to remove or fix all of the factors that contribute to falling, but we should improve where we can to reduce and minimize the overall fall risk. Thank you.